Welcome everyone to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for February 9th, 2023. Today's CME activity code is 487536. I see some new names in our participant list, so we welcome anybody that's new. Please join our YouTube channel. These are all posted eventually by Dr. Baxi on our YouTube channel. And if you're not on our mailing list, please let us know. We've got a fun case today. I'm going to start with a follow-up of another case. As usual, we have nothing to disclose, and our patient privacy is well preserved by changing any identifiers. So I'm going to start with a case back from about a year and a half ago, because I have some follow-up. It's kind of interesting.
Go ahead, click on the screen, Roger. Yep, you're controlling.
We've had a lot of talk recently about membranous and all the antigens, so I think this is kind of timely. This was a patient was a 43-year-old male with a past medical history of CIDP, chronic inflammatory demyelinating polyneuropathy, who came to the hospital with anasarca and shortness of breath, normal renal function, but very low serum albumin. Urine had really nothing in it but protein, and serologically there was really nothing there. He was PLA2R negative. So he brought to the hospital. He did have a DVT, and he was started on Lovenox, but he had a VQ scan, which was indeterminate. He was diuresed and had been already treated with IVIG for his CIDP prior to that, which has some relevance as this goes through. There's really nothing on past medical history, et cetera. Medications, nothing really important that I need to go into. On physical, he was basically a very cachectic, muscle-wasted young man, middle-aged man with a low blood pressure. He had anasarca. It was really pretty awful. And you could see by his creatinine just how cachectic he was. He had a BUN of 25, a creatinine of 0.3. His albumin was 0.5, but his cholesterol was 139. His PLA2R antibody was negative. The rest of his chemistries, I'm skipping over, unremarkable. COVID-19 was negative. Hepatitis studies were all negative. His protein creatinine ratio was 6 grams per gram, and his kidneys appeared normal. So when we looked at this case, we kind of talked about it. We focused on a few things. One was his sacral decube, and that's the consideration that he might have secondary amyloid from chronic infections. Another was the fact that he had a DVT and the concern that possibly a little stronger association with membranous. He had a very low albumin, was very nephrotic, and that always points us towards minimal change disease, but his cholesterol was only 139, and I believe we actually went into that a little bit. That would be highly unusual. And it gets back to this CIDP, and I remember as we were talking about this case, in the text box, people started talking about CIDP associated with membranous and anti-contactin antibodies. Now, that was a year and a half ago, and now it's a common thing on the list. But I have to give our audience credit because they're so damn smart, which is we're so grateful to have them. Because remember, this was in October of 2021, and I went back and after that and found some of these papers. So the first one that was really big was an AJKD just 2 months earlier about contactin-1, a potential new antigen target in membranous associated with CIDP, and then in one after in November of 2021, and then one in December, which actually talked about remission with rituximab. So talk about timely, and I swear, I'm reading this, I had absolutely no idea as I'm presenting the case, and the audience is telling me what it is. It was humbling and rewarding all the same time because I'm so proud of having everybody involved in this. So here was his biopsy. This is a silver. You can kind of see some here. I'll go a little higher dose on it, a little higher power on it. You can see some of the spikes there. And on immunofluorescence, a very strong pattern consistent with membranous, and then the EMs here. You can kind of see these really massive deposits, subepithelial deposits. They've been there a while. They're not intramembranous, but they're not fresh either. So very, very severe and a fairly extensive podocyte effacement here. So membranous, and I went into this case not even knowing this association with contactin, and left it with a very, very interesting, but that was a year and a half ago. And since then, now we have what was it, the last time I talked about it last week, 15, 16 antigens or something. Contactin being one of the earlier ones after thrombospondin, Anel, et cetera, exostocin. So based on that, I'd already planned on giving him rituximab, but it was kind of nice to know that rituximab had been shown just 1 month after I saw him as an effective treatment for contactin-induced antibody membranous in this condition. He was anticoagulated, put on a statin, but he was lost to follow-up. And he lives at home. He can't even get himself to an ambulance. It's a very complicated, long socioeconomic problem that was there. But he came back 9 months later with anasarca. I think he came for his feeding tube being replaced or something. And so now 9 months later, he has a protein creatinine ratio of 31 grams per gram. Now he was on IV albumin, so that's part of it, but clearly he was not in remission. His creatinine was still 0.3, his serum albumin was still 0.5. And so we talked a little bit about rituximab resistance at the time. And what we know depends a lot on what we know about PLA2R, because there's so much data on that now. And we do know that it responds faster with a cyclophosphamide-based regimen than a rituximab regimen. That's something to think about. But 9 months not being enough time, there is definitely a lag. But in 9 months to not have any improvement, I think is a little bit odd. We also talked about the decreased bioavailability of rituximab. With being that nephrotic, maybe it's all lost in the urine, and maybe we should increase the frequency of it, follow CD19 cells to make sure that he had an adequate dose. And we talked a little bit about rituximab neutralizing antibodies, because rituximab is a human mouse chimeric antibody, and so it's a high percentage of patients will form antibodies. Doesn't mean they all don't respond, but there is the consideration for a role of ofatumumab or obinutuzumab, which are both humanized, pure human anti-CD20 antibodies. And this is just one of the really nice cases where in a patient that has refractory PLA2 membranous, which is again where we have most of our data, and it's very useful because you can also not only follow the proteinuria, but you can follow the PLA2R. And you can see here the patient got Cytoxan to start with and rituximab, and you could say, well, maybe there wasn't enough time, but there was no evidence that things were getting better over from month 12 to month 18, and then they gave obinutuzumab and had a very nice response. And it was a really nice case report, and kind of makes you consider what are the options for refractory. And the other possibility would be something like a combination therapy where you give rituximab and low-dose cyclophosphamide. Now, these are all reports. None of this is controlled, but this was out of Harvard, I believe, by Dr. Niles, and he gave 2 doses of rituximab with 2 months of oral Cytoxan. They called it lower dose. It really wasn't that low, but it wasn't a full dose cyclophosphamide that you might use with the Ponticelli protocol. And then a prednisone taper. And what I thought was interesting too is they gave it another dose at 4 months, where a lot of us are just so used to giving another dose at 6 months. This is a fairly aggressive therapy for membranous. And then they followed it up with their long-term follow-up. So that was the first paper was short-term. This is a long-term. And you could see, this is a really good response. Almost everybody that a partial or complete remission. And so again, this isn't necessarily controlled. We don't know that it's better, but it's something to consider in some patients that are either refractory, and that's what I was thinking about, that he was refractory to the rituximab. I wasn't willing to wait any longer. It had been 9 months and there was no effect. And it'd be a lot easier for me to do this than to get one of the alternate CD20 drugs. That would be pretty tough for me to get. So what did we do? So this was 9 months after his initial rituximab induction. I gave him 2 more grams of rituximab. And then I gave him cyclophosphamide, 100 milligrams a day, and I gave it to him for 3 months. We cut his prednisone very quickly because, he had the cubes and everything else. We tapered it out very quickly. And of course, then he's lost to follow-up again. And I had no idea, but a year later, he got admitted for, again, just a complication associated with something, and he was in complete remission at an albumin creatinine ratio of 182. So it's really interesting, because I've been preaching that these are all antibodies, and we just got to get rid of the antibody. Of course, it would be great if I had an assay for anti-contactin antibodies and to actually show that they went away, that they were present and they went away. But I believe that's what happened. I just thought I'd give some follow-up on that. And we're going to try to do that a little bit more. We've had some great cases, but we don't always have the follow-up. So this was a little long, but our case isn't that long today, and we'll go to our regular case today. I think Kelly's going to read the protocol. Dr. Schlattman, our second-year fellow.
Give me 1 second, Kelly. I will give you control.
So our case today is about a patient, a 38-year-old Asian female with no significant past medical history, who was referred to the nephrology clinic for proteinuria, which was actually incidentally discovered during routine laboratory testing about 4 months prior. She routinely gets her blood checked yearly as part of wellness checks for insurance purposes and has never previously been told of any abnormalities. This year, she also gave a urine specimen for the first time, and this showed proteinuria with a UAC of 950 milligrams per gram and a UPC of 1500 milligrams per gram. UA was otherwise negative for blood and had no WBCs and RBCs. CBC and CMP were both normal. She was started on losartan 100 milligrams per day and was told to return to clinic in 4 months. She denied shortness of breath, chest pain, abdominal pain, rash, swelling, photosensitivity, oral ulcers, abnormal periods, and NSAID use. She had COVID about 2 months ago and is now fully vaccinated, and she's not currently on her menstrual cycle. Like I said previously, she has no past medical history, no past surgical history. She does not drink alcohol, use drugs, or tobacco. She has no family history of kidney disease, autoimmune disease, or cancers. She does have one child who is a teenager and is currently healthy. Her pregnancy was uncomplicated, but born via C-section. She has no allergies. She wasn't on any medications. She specifically denied any over-the-counter medications and supplements. Physical exam was overall normal. She had a normal blood pressure, 120/70, with a normal heart rate. She was 5'2" and about 65 kilos, giving her a BMI of 27. And then furthermore, she didn't have any bilateral lower extremity edema. Heart and lung exam were normal, no rashes. In terms of her labs, her CMP showed a sodium of 141, potassium of 4.2, chloride 105, bicarb was 23, BUN was 15, creatinine 0.6, glucose was 120, total protein was 6.7, albumin 3.7, calcium was 9, total bili was 1.2, her alk phos was 75, and her liver enzymes were within normal limits. Her CBC showed a normal white count with a normal differential, hemoglobin of 13 with an MCV of 88 and platelets of 300. Her UA had a specific gravity of 1.007 with a pH of 6.5, 1 plus protein, 1 plus blood, 0 RBCs, 0 WBCs, 0 squamous cells. Her UAC was 950 milligrams per gram and UPC was 2 grams per gram. Her Hep B surface antigen, Hep B core antibody, Hep C antibody, HIV antibody, complements, ANA, ANCA, anti-PLA2R antibody were all unremarkable or negative. Her SPEP and UPEP did not show evidence of a monoclonal protein. Her renal ultrasound showed a right kidney that measured 10.5 centimeters and a left kidney that measured 11.5 centimeters. And it didn't show any evidence of hydronephrosis or abnormal echogenicity. And so then a percutaneous renal biopsy was performed.
Any questions on the case?
Hey, Kelly, did the patient have any recurrent urinary tract infections going up or any other childhood issues?
Nope, she denied that.
No history of preeclampsia with that one child, I'm assuming.
No history of preeclampsia, no complications.
Let me just ask, we saw her and she was not nephrotic. She had some proteinuria. She looked great, no blood and normal blood pressure, normal creatinine. So we put her on an ARB, and then her proteinuria got a little bit worse. And of course, that's when we decided to biopsy her. Was there anybody who would have waited longer? Anybody think that we rushed into a biopsy? Bill, what do you think? Go ahead, Dick.
Biopsies in patients with non-nephrotic proteinuria isolated are very controversial because generally speaking, you don't find anything that you can treat. And whether treatment is needed anyway. This patient only has a UPC of 1,500 milligrams per gram, which would equate to a 24-hour protein of about 2 grams per day. So she's right on the borderline of where many people would biopsy, many people would not.
And that's kind of that's the way we felt. That's why we put her on losartan and figured, we'll get her proteinuria will go down to 900 or 700 or something, and then we'll kind of just watch her because we didn't think we'd find anything. But her proteinuria went up, so that's kind of what I guess we thought it was the thing to do. Bill, would you have waited or biopsied?
You could actually, I think, make an argument to do either biopsy earlier, right when you see her, or wait even longer. So those are the exact opposite. And so I like Dick's comments that it's controversial, because I think you could really do either. A lot of times, it also depends on how worried the patient is, and if they want to know what the answer is. I don't think that you'd be missing anything alarming by waiting a little longer, but I could see biopsying her either way.
Okay, we have a poll now. Let's see what people think. So what do you think this patient has? A podocytopathy? Think she has membranous? Do you think she has IgA nephropathy? Do you think that's something rare?
I think we need some poll music from now on. I think we need to come up with some sort of Jeopardy type.
Yeah,
Yeah.
I agree. I
music.
completely agree. That's my
I
project.
mean, this is Dr. Robbie's next project. He'll spend more time on finding the right song for this poll than he will on anything in nephrology. That's for sure.
Bill, I would be offended, but you're right. That's the problem. A few more, maybe? A few more people vote. It's all anonymous. Okay, I think we can end it there. We've got about half the people are picking IgA nephropathy. We've got 15% say membranous, 12% say podocytopathy, and 21% something rare comment in chat, which is a good addition there. So let's pass it on here to discuss to see what people think. Bill, what are your thoughts about this case?
Yeah, I'm in agreement with the poll in the audience. I mean, I think there was a question there in the chat about tubular or glomerular proteinuria. I think it's definitely glomerular proteinuria. We have a gram of albumin. So I would look for a glomerular lesion, and I think even though she didn't have blood on her initial urinalysis, and I'm assuming she didn't have proteinuria in blood during that first pregnancy, I think IgA nephropathy is probably still the most likely. Her urinalysis did have dipstick blood, and oftentimes the urine looking for cells, once it gets sent to the lab, those cells have lysed. And so sometimes when I see 1+ blood, I think, there may be some actual blood there, as opposed to the classic board's question of that being rhabdomyolysis or something silly. That's not really relevant in this case. So I think IgA nephropathy would be, she fits the demographic for sure. She's got low-grade proteinuria and maybe some hematuria. So I think that's my most likely. I think a subnephrotic membranous is also maybe next on my list. Her PLA2R is negative. So when you're saying something rare, we're already hitting something rare there. If it's a subnephrotic membranous that's not PLA2R, it could be one of your 15 antigens that you just talked about. And I would actually say that I'm going to guarantee that she does not have a podocytopathy. Now, she may have, just because she doesn't have a lot of proteinuria and her albumin's fine, and it just doesn't fit the clinical scenario that you present with the podocytopathy. She may actually have a FSGS pattern of injury, but if she does have that, it may be one of the FSGS patterns that's more consistent with either genetic, familial FSGS, or the undetermined FSGS, as opposed to a primary FSGS where you have that podocytopathy.
I think you're being generous. I mean, giving her, I'm surprised, giving her IgA nephropathy with, 1+ blood, no red cells, normal blood pressure, normal creatinine, that much proteinuria. I don't know. I think you're being generous, but you've made your case, and that's legitimate. I think you're putting a lot of weight on her ethnicity.
That's right. Her ethnicity, her age, maybe a little bit of blood.
Yeah. Dr. Rubin, what are your thoughts on this case?
Not much more to add. I mean, I think this new term collagen 4 diseases is another thing to consider, such as thin basement membrane outports with its different manifestations. Sort of that. I mean, is what Bill already mentioned. Nothing much more to say.
Casey?
I have nothing to add. I agree with IGA.
How about the
We're gonna
COVID?
be done in about 5 minutes.
How about COVID? She had COVID 2 months ago, and is that anything? I mean, I know this, we don't know before, right? This is she's never had a UA before.
Her
She gets-
COVID was between her first presentation and her follow-up. So we
I
saw
see.
her, and then she had COVID in the interim. But that's a good point. I mean, the proteinuria kind of got worse from COVID.
COVID's
Very
also
good point.
associated with the IGA in addition to our typical COVAN and TMA that we see, and of course the just AKI. But there's definitely been case reports of IGA. Now, if it's is it incidental, is it COVID related? But I think that's always on the
I think
list. now.
Covan would be unusual in an Asian, but it's much more strongly tied to APOL1 high-risk genotypes. But I think anything's possible. In the
Just a-
chat, we've got a possible Asian, probably IgA, and an ALEC amyloidosis. That's I suppose that's a possibility. ALEC 2. I don't know that. I just looked up.
Maybe
Um,
February.
Yeah. I just looked up. The ethnicities of ALEC 2, and it goes way beyond Hispanic. There's Punjab. There's American Indian, Native American Indian. There's a Canadian tribe, and there's a couple other areas. I think, Bill, you saw that tweet I had. If you,
Yeah, 85% are still Hispanic, but then the other 15% comprise the rest of known like too.
yeah. I don't know about how strong it is with Asian, but that's always a possibility.
We
It is
usually when it's
ALEC is
albuminuria,
an
Just, I have a comment about diagnostic testing in this patient before biopsy.
okay.
Because genetic testing is now becoming so relatively inexpensive, would anybody do a genetic testing for a collagen 4 problem in this patient before the biopsy? Or would you just prefer to wait and see whether the biopsy shows any lesion compatible with a collagen 4 glomerulopathy? And the second, what about asking the patient about her birth weight? Proteinuria can be a late manifestation of nephron underendowment, and we don't ask these patients often enough whether they were born prematurely or with a birth weight less than 2.5 kilograms.
It's a good point. I slowly, once in a while, I ask. I know that one of our fellows, Melanie, it's automatically something she asks now. I hope she's smiling somewhere, because she's really bought into that. Not bought. I mean, it's fair. It's a good question. It takes a while to get there, to think of that as a natural, rash, whatever. Were you born prematurely? Do you know your birth weight? It's a good point, Dick. I know that you've been a real champion of that, and I think it's only a question. It's a simple question. As far as the other thing, getting a genetic test or then waiting to get a genetic test. I mean, I think if you're going to get a genetic test that's going to influence you, I think you should get it first. If you think it's going to influence you, it doesn't, as opposed to seeing because it's very reasonable now. It's easy to get. I mean, there are certain situations where you don't want to wait. This is clearly a case where we could have waited. There was no rush on this whatsoever. And we could have sent it off. It takes a while, but I think personally, at least a collagen disease, I think is unlikely with the lack of hematuria, but that doesn't mean it's not there. And, the more we do these, the more we're learning. And we've all done some genetic tests and been surprised. So, that we may get to that. It may become routine now that before we biopsy some of these odder cases, certainly with some of the focal sclerosis that, that Bill brought up, some of these genetic, that I think it'd be reasonable to get that first. And I'll be honest, I didn't even think of it. We just sent her for biopsy. Her proteinuria was going up, and we just sent her for biopsy. Dick, what do you think she has?
IgA nephropathy, I would agree.
Okay. All right. time to, oh yeah, so time for the wheel. Is the wheel still up?
Yep, the wheel is up.
Saba. Saba's one of our first year fellows. Is she here today?
She's on vacation.
Oh,
It's on
okay.
vacation.
Thanks, Kelly. Boy. Ah, it really wants her. We're gonna have to fly her back.
We
You
forgot
have
to
to
move the
move the
weight.
magnet.
Yeah.
Yeah, the mag. I got to move the magnet. Hamoud. Hamoud is a first year fellow.
All right, Hamoud, give me a second here. I'm gonna give you.
This is this will be his first read, so we got to support him here. Not worried about him, but you know, this is tough to come. The very first international.
Way to build it up and not stress them out. That's great.
Hamoud, can you hear us? Hamoud, you're unmuted. We can't hear you, Hamoud. Still can't hear you. Do you want to try someone else's computer in that room? I see Melanie's there.
Can you hear me now?
Yep, we can hear you now. Perfect. I'm going to give you control. Remember, there's a lag. So go ahead and click on the screen. Yep, and you can advance the slides in the bottom. Yep, go for it.
All right. Okay. So here we have two cores. Overall, this is the Mason trichome strain. I'm looking for any blue substance chronicity. I don't see much over here, maybe 5 to 10% or 5% or less than that. I do see a few gloms here, and the tubules seem to be back to back. From here, I don't see any interstitial infiltration, anything like that, but maybe I'll go forward and.
Okay, sounds good. Yep, just very focal fibrosis, like you said.
Here, this looks like a PAS stain. Judging from this, I think there is some mesangial hypercellularity, more than I think 4 cells or something in certain areas, like here, if you can see my arrow. Loops.
Yeah, there's a mesangium expanded as well by matrix.
Okay, right. Loops.
Oh, no, I was asking you, does the mesangium
sorry.
look expanded?
The matrix, a little bit maybe.
Okay.
Like I see a little deeply stained area in between cells as well. Maybe that's.
Yeah, so there's some mild mesangial expansion.
Okay, yeah. So mild mesangial expansion, and in terms of membrane thickness, I think it's okay. I don't feel like there is any thickness. In terms of the rest, the tubules, they seem okay. They're back to back. I don't see any signs of edema or any hypercellularity in the interstitium.
Yeah, the only thing I'd point out, the tubules have good brush borders. There's a distal tubule at 2 o'clock. You could see all the nuclei. Yeah, right there, that's a distal tubule. And down at 6 o'clock, there's 2 or 3 atrophic tubules. Yeah, right there. Not that one, to the right of it. It's got, yeah, those have thickened basement membrane, and those are atrophic and kind of shriveled. So you could see the comparison between a normal tubule and atrophic tubules on the PAS stain.
Okay, makes sense. Right. So here we have an H&E stain. This looks like a lot of infiltration here. If it's a kind of a urinary space, it might be a descent.
All right,
And
so do you see that pink blob there? Can you point on that? Oh, far over on the left about 7 o'clock,
oh, this one.
right
Okay.
there. Yeah. Okay, so you got some, do you know what that, and then also around it
Some
are scattered
necrosis?
black dots. So do you know what we call this lesion?
Is this necrosis?
Yeah,
Like
this is a
fibrinoid necrosis?
segmental necrotizing lesion. That's fibrinoid necrosis, the pink material. And then the black dots, it's called charectic debris or nuclear dust, nuclei that are breaking apart.
Okay.
And no doubt there's some infiltration of cells here, and there it may form a crescent, but I don't see formation of a well-formed crescent here. As Dr. Whittier chatted, this is a segmental necrotizing lesion.
Okay.
Okay, next slide.
Oh. Well, this is the glom, and here it seems that there's a lot of infiltration.
Well,
And
proliferation, right?
yeah,
What kind of cells are those?
they look like lymphocytes.
No, those are parietal epithelial cells. That's a crescent.
Oh, okay. Okay.
So that's formed by parietal epithelium that lines Bowman's capsule in a reaction to a break in the basement membrane. And so that there you have a kind of resembles a crescent phase of the moon. So that's a cellular crescent.
Okay.
Infiltration would imply their cells that are not native to the glomerulus being marginating into the glomerulus. So this is not infiltration, this is proliferation.
Okay. So the previous lesion was like different than this one.
And it's the same mechanism, right? It's the same mechanism, a segmental necrotizing lesion.
Okay.
In this case, we have formation of a crescent. It's probably a little bit older by a few days, a little bit more progressed. You know, a segmental necrotizing lesion is very early type of lesion. And then as the parietal epithelium gets stimulated by the necrosis and the serum that's leaking out, it forms this crescent.
Okay. All right. Thanks. Other than that, the tubules on the periphery, again, I didn't see much. I think the rest, they look normal. Maybe a little bit hypercellularity. I see a lot of nuclei here.
I would say more on the left side of the glomerulus. There's a little infiltrate. Yeah, there's some mild lymphocytic infiltrate there.
Okay. Then I think we're back to PAS again. Here I can kind of clearly make out this is possibly a crescent. Just
you could remove possibly. That's definitely a crescent.
just kind of squeezing the rest of glomeruli here.
Yeah, so you have a good view there of the extraglomerular proliferation of the parietal epithelium forming the crescent, and then glomerular tuft. It looks very hypercellular. A lot of capillary loops are filled with cells and are not open.
Right.
Yeah, so 3 out of 13 glomeruli had crescents or necrosis. Yeah, we saw all 3.
Okay.
3 out of 13 on the light microscopy. All right, let's go next slide.
Here, I didn't see a lot of open loops, and again, I see this necrotic kind of lesion.
Well, so no doubt this was a necrotizing lesion, but I would characterize this more now as a segmental scar. The fibrinoid necrosis is gone. The charectic debris is gone. You have adhesion there and kind of consolidation of the tuft by scar tissue. So no doubt this was necrotizing, but this is now segmentally scarred.
Okay.
I think before we get to the immunofluorescence, it's just good to point out the differential here and how important the immunofluorescence is in this case. I mean, if it's a full house, it might be lupus in a young Asian woman that no one really brought up in the differential. If it's posse immune, then we've got to be retesting for ANCAs to make sure we did them right. If it's IgA alone, then it's going to be, IgA with potential crescents. And so there's a lot here that we don't know, and the immunofluorescence is going to be very telling.
All right, so one more slide.
Right. So here we see the silver stain, and I see there's a lot of broken membrane material.
Yeah.
Chest is kind of shriveled up, and probably like this crescent is again kind of pushing everything over there.
Yeah.
I don't see any spikes or any gaps there in particular along the membranes. Yeah.
Yeah, I mean, again, then the analogy is these necrotizing lesions are like an explosion. A grenade goes off in the glomerulus, breaks the capillary loops, and you can see what's left here, fragments of basement membrane, and then those cells there are the crescent that we saw on the PAS stain.
And the fibrin would then go into Bowman space, which we saw in one of the earlier ones.
Yep. All right.
All right, so this is immunofluorescence is strongly positive for IgA. This looks like it's a mesangial deposition.
Yes.
Mostly, and yeah, I think most of it, like it's all of it is mesangial deposition. And now we have the EM. So just to quickly reorient myself, so this area will be your like capillary. This will be your urinary space. I see these some obvious depositions here a lot. I think this is the mesangial part, or maybe part of the membrane, or just mesangium here.
Yeah, those are mesangial deposits corresponding to what we saw on the immunofluorescence.
Yeah, multiple areas here and
Yeah.
here. Yeah, the porocytes, they seem okay all along.
Yeah, they look relatively preserved.
Let's see.
There-
Maybe here's
Some focal effacement. Yeah, focal effacement there.
some focal effacement, but for the most part, yeah, they look preserved. Yeah. Anything else that's here?
No.
Yeah, so here we have like a better view of most of the mesangium. We see a lot of deposits here, here, here. Again, the photocytes mostly, they look okay. I still don't see any deposition along the membranes. It's mostly in the mesangial area.
Yeah.
And you don't expect any other deposits based on your immunofluorescence, right?
Yeah.
Because mostly in the mesangium. Yeah.
Right. Okay, so this was crescentic IgA with some fibrinoid necrosis.
Nice read. Very, very nice job. I'm going to give you a silent applause for your very first read.
Thank you.
So a little bit of a surprise here. I think we'll before we discuss this a little bit more, I have another poll based on what you saw. How would you initially treat this patient? Would you give this patient a cyclophosphamide-based protocol? Would you give a steroid-based protocol? Would you give a conservative therapy for now, RAS inhibition, SGLT2 inhibitors? Would you give rituximab, or would you give MMF? So we've got, it's nice to see we've got a little bit of everything here. Dr. Reed had mentioned that this was in the communities. In fact, I did put this in the communities earlier this week because I can't think of a disease that's harder for me to come up with treatments for than IgA nephropathy. It's so heterogeneously, clinical heterogeneity and pathologic heterogeneity. And there's, KDIGO has changed its approach a little bit to crescentic IgA, but I think every case is different and every case is individual. And so I put it out there, and I'll tell you later what people said, but I wasn't doing it to be provocative. I was doing there to see really what people would say. you know, on the one hand, she's pretty stable. On the other hand, she's not. Our number one vote here is for steroid-based protocol, but it's hardly a mandate because we've got 34% there. We've got some conservative therapy at 25%, cyclophosphamide at 28%, rituximab 6%, and MMF at 6%. So a little bit, so it kind of supports what I was thinking. Like, I'm not sure what to do. I had my ideas, and I'll tell you what they are after we get through it. If you can just advance, I'm really curious now. Bill, what do you think about all this? I mean, how surprised are you? I know you predict IgA. Did you think that she'd have this lesion?
No, absolutely not. I would not have predicted crescentic IgA, but here we are, especially in the absence of hematuria. I'm very surprised. I was going to think that it was going to be kind of a not as active inflammatory IgA.
And what would you treat?
I mean, it's all over the map. I wrote about this a while ago when I said spin the wheel when that HOU How article came out with Cellcept and low-dose prednisone as a treatment for crescentic IgA, and basically saying just like we spin the wheel at our biopsy conference, you could spin the wheel and pick any number of treatments for crescentic IgA. KDIGO suggests that it doesn't really matter on the histology with crescents or segmental necrotizing lesions, and you should be treating them with aggressive therapy if they're an RPGN. That's KDIGO's take. And we've all seen cases that don't progress that have one crescent and less than 10% of crescents. And, so I think it's tough. If I see a lot more of them though, and it's greater than 50% crescents, I'm despite KDIGO's recommendations, I'm a little bit more aggressive with my therapy, and I may be more aggressive at trying immunosuppressive therapy first. I think that a clinical trial would be a good idea, but in the meantime, if I don't have that, this was what, 30% crescents? I hate even making a decision based on these numbers because it's almost silly.
Do you remember Dr. Corbett a few weeks ago? He had a crescentic IgA.
Mm-hmm.
It was one
out of 50 or something.
Yeah, 1 out of 30 or something like that. It was very small, and I'm not. I maybe this is picking a little bit, but I don't think his crescents were as angry as these crescents. His one crescent.
Yeah.
These are. I find these to be really, really nasty looking crescents to me, or necrotizing lesions.
And we could see these and know, like in HSP, that it's self-limited still. It's the inflammation on the biopsy doesn't know. And I think that's what they're kind of saying, is that we really shouldn't be treating with aggressive therapy unless we have a clinical deterioration with acute kidney injury. Boy, that's really hard for me to do. That's really hard for me to do right now. And I'm somewhere between believing my own clinical anecdotal experience and believing the literature, and that's not a good place to be. I mean, we should be focused in on believing the literature. But for me, I would do something. I would immunosuppress her.
That's putting your nickel down.
Yeah, I mean, I would. And then what would I choose? I'm going against the literature here, and we just sent out a publication this on this IgA with crescents alone. But these, as you said, look juicy and angry, and it worries me. And she's young, and it's a lifelong disease. So I would at least induce her. And the next question is just as confusing as the question of whether you need to do it, because there's all these different things that we could use. It could be something like prednisone alone. It could be all the ones that you had up on the chat there. That's a good point. The Asian study by How, or HOU, however you say, Ho maybe, that Reem just kind of pointed out was in AJKD, and what they did was they randomized patients to Cellcept and low-dose prednisone versus Cellcept and high-dose prednisone, and they found that it was 6 months worth of Cellcept, and there was actually a legacy effect, and that's only been shown in Asian populations where Cellcept seems to work. It hasn't been shown in any other studies that I've seen where it's successful for the treatment of IgA. So yeah, you could try that.
Casey, you've taken I think you always taken a more conservative approach with some of these, at least with HSP and some of these IgAs. How do you feel about this?
I'm between conservative and steroids. That's kind of where I'm not going beyond that. I've had a few of these cases where they've done well over the 5 to 10 year follow-up. They haven't really progressed. So I have usually used steroids, and I don't know if the reason they haven't progressed is because of that or because of just the fact that they are this disease is not necessarily as the same thing as a vasculitic necrotizing lesion. And I don't know what juicy versus not juicy crescents or necrotizing means. I mean, it's crescents. It's just necrosis. So I'm gonna do steroids in addition to the RAS and SGLT2.
I can maybe defend that. I mean, you could have crescents in a post-infectious GN, and they don't necessarily make, these are completely destroyed, these glomeruli. And I just can't see them doing well. But you're right. That's just me being a little bit maybe silly.
Yeah, I mean, I don't know. I don't know if the cut, how many glom samples you get. I think there's a lot that can go into like, I mean, you saw some fibrotic, so fibrous crescents. You saw some already scarred over, segmental scars. So clearly they do tend to scar. Whether this is culminating into something bigger that would lead to deterioration of renal function long term. I mean, right now she has a normal creatinine, normal blood pressure, normal albumin. There's clinically, we were talking about not biopsying this lady, right? So I think she's probably doing well right now, and she's probably going to do well. So even the steroids, I feel like maybe a little much, but I feel like now that we have histology and their crescents and necrosis, maybe the steroids will have some role. So I'm going to go with steroids.
So Dr. Glassick, as an author of the testing trial, what are your thoughts about steroids here? Because was this patient represented in that trial?
Well, I have a couple of comments. First of all, I really like Bill's comment about KDIGO's recommendation in October of 2021 that was very strongly against using histology to make clinical treatment decisions. They said several times in their paper that clinicians should not use the appearance in histology as quantified by the Oxford MES score in making decisions about what drug to use in the treatment, except in patients with rapidly progressive deterioration of kidney function. So if you want to follow an evidence-based guideline, you definitely would not pick any of the drugs on the list of your, except for conservative therapy. Now, subsequent to the KDIGO guidelines, of course, testing has been published showing that moderate doses of steroids without much side effects are beneficial, at least over the short term. They have not yet published any post-hoc analysis of KDIGO scoring methods in determining the outcome, but we do have post-hoc analysis of the STOP IgAN trial, which suggested but did not prove the fact that the extent of crescents did predict the beneficial effect of steroids. So from an evidence point of view, we don't really have the complete story yet as to whether steroids really are indicated in so-called crescentic IgA nephropathy. And we don't have much information yet on whether the extent of crescents and their nature have utility in making decisions about treatment. All that having been said, I would have treated this patient with steroids because I agree with you, Roger. These are angry looking crescents with necrotizing lesions that are very likely going to lead to a scar. They already have led to a scar in one glomerulus in the sample. So I would give this patient the benefit of the doubt and treat with a course of steroids. I probably would also give careful consideration to adding MMF at some point in her disease evolution, because I think MMF is effective in Asians. I'm not impressed with non-Asians, and I wouldn't use it if this patient were of European or ancestry, but because she's Asians, I think I would seriously considering MMF but not cyclophosphamide. The evidence is just not there for cyclophosphamide, and it's too potent and too hazardous an agent to be used in weak evidence.
I can tell you that, 3 years ago, I would have been giving this patient cyclophosphamide because we kind of, our rush approach to this was that this is a necrotizing glomerulonephritis. How is this any different than an ANCA-vasculitis? And I don't think that's right. It took me a long time to get off that, that bandwagon. It's hard for me to believe that as you pointed out, KDIGO and Bill pointed out, it's really not, you can't make a decision on it. I don't know, it's very hard for me to do that. What makes this decision a lot easier for me was the testing trial and the fact that the lower dose in the testing trial did quite well. And that's really not a lot of steroids that, as with less side effects as was in the higher dose. So could we?
So I have a question. So we talked about not using histology, and this woman, it looks fine and everything is okay. So then why are we using histology to direct treatment then?
Well,
I think it's after the KDIGO with the low dose testing trial showed that steroids were beneficial, and then that may be that we're saying that there's been updates to KDIGO since KDIGO was published.
Right.
So
it's hard for me to abandon that. It's hard for me to abandon that pathology and just let that go. It looks terrible to me. It just looks awful. And I mean, she's 40. She knocks off 3 a year, 10% a year, and she's going to be in trouble. Now, I don't know that. It's an easy decision for me because she will tolerate this well, and it's not a year of high dose prednisone or anything else. I think she'll tolerate it well. Like I said, the fact that the low dose testing in the testing trial makes me feel a lot more comfortable than, because I really look for every reason not to give steroids. But the more I thought about it, the more I really felt that's what I think where I'd like to go. Can you
click on the screen,
advance?
Roger? Yeah, go ahead. Click on the screen. Yep, that's
there
you.
We go. Okay. So this is the testing trial, and on the left we've got the full dose cohort, which had the higher complication rate, which then went to the low dose cohort, and you can see this pretty remarkable separation. This was just the endpoint of 40% delta GFR, decrease in GFR, and it's fairly significant here. The dose that they recommend is 0.4 milligrams per kilogram of solumedrol, and then decrease by 0.4 every month until you get off, and that's the equivalent of 5 of prednisone. She weighs 60 kilograms, so that would be 30 milligrams of prednisone for a month, and then 25 for a month, 20 for a month, 15, et cetera, to get her off. That to me is pretty tolerable. And kind of that's what I thought that we would go with here, is just follow that protocol. This, you brought up, I don't know if it's the same or how, Bill, it is. Okay. This just came out in JAMA in the last week, and people brought it up in the chat box as well. Another, it's in China, pure China study, 170 patients with biopsy-proven IgA nephropathy. They were put on a short period of an ARB for 3 months, and if their proteinuria was still greater than 750, they were randomized to MMF or nothing. And the primary outcome was very nice, our favorite, the doubling of the serum creatinine. And you can see here that, this is after it started separating in about 1.5 years, but a pretty nice separation here between the difference of this doubling of the serum creatinine. And so, this was put out on Twitter. I think it was Swapnil Hiremath that, when he first saw it, I think this is pre-publication. It might have been early release or something. So we put it out there, and this is what Dr. Glassick came back with, and he said there were some issues here. One is single center, 2 open label, all Chinese, no SGLT2 inhibitors, no stratification by the MES score. And, were similar results found in non-Asians? Probably not. I think those are all, legitimate comments. On the other hand, it depends how you feel about MMF and the safety of MMF and the empiric use of MMF. It was not a high dose. I think it was 1.5 grams. I think it's a reasonable thing to do. and but it's maybe not it's not the best study. You know, having said that, there's a pretty nice separation, and it doesn't mean that that the study's not true. It just may not be as reliable as if it were, you know, not open label, et cetera. So what I decided to do is I decided that, of course, I put this, I put the glom here because it just weighs on me so much. But I said, let's go with the testing trial, the low dose. I'll put her on 0.5 milligram a kilogram of prednisone a day, decreased by 5 months. It's 6 months, not 6 weeks. It'll be 6 months total of prednisone. And about half of that'll be, you know, 15 and lower. So it's really not that much prednisone. And then I think I am going to put her on MMF because I think it's reasonably well tolerated. She is Chinese. It's a Chinese study, and there's a couple of them now. And I'll put her on, I wouldn't say indefinitely, but I'll keep an eye on her and maybe just to see how things go. Eventually I'll get her off. And the problem is that we don't really have a lot to follow with her. We don't have hematuria. I don't want to wait for her creatinine to go up. Do I stop it and biopsy her in 2 years? I mean, all those are possibilities. I don't know the answer. We'll deal with that as we get to it. But my plan is to treat her with prednisone and then put her on MMF for a while, and we'll see how she does.
Roger,
Yes.
the
Mario.
main trial looked at patients with progressive disease, which your patient is yet to show. So would you hold off on the MMF till she shows evidence of progression, or you will jump regardless of the stability of the kidney function?
Yeah, I mean, I don't know. You know, she's got 10% or so crescents, and yet her creatinine is actually almost super low. You know, I don't think I can rely on her. If I believe this is a problem and that it can progress, I don't think I can rely on the creatinine. So I'm going to automatically just give it to her. Again, if it were cyclophosphamide, no way.
Well, you
Or
see,
3 years of CNI, no way.
these are the parts that I don't understand on how we as nephrologists approach these cases. On one hand, Dr. Glasser very nicely has stated of the kidney biopsy and KDIGO basically say, don't look at it. And yet, in his nice comments, he says that the main study was not stratified for the Oxford MEST classification. So I don't understand the dichotomy. On one hand, we say, let's look at the data. The data says, don't give MMF unless there is progression, but yet you look at this ugly biopsy and you say, forget what the main study tells me. I have the itch to give CellCept. So this is the part that I think create confusion among practicing nephrologists on what really should be done.
Yeah, I don't know how to answer that because it's a fair criticism, and I think it gets back to what I was saying, just how hard it is to make any decisions on IgA nephropathy. But I think in the end, we have
years ago we would have said this is a crescentic IgA, and if it progresses, this is a malignant IgA. And as you so eloquently stated, she would have been on Cytoxan. But things have changed, and I don't know. Those things look ugly, and actually, at 2 o'clock, I would venture to say there's rupture of Bowman's capsule, which Dr. Glasser has pointed out in the past as a bad prognostic sign in a crescentic GN. So to me, biopsy is very helpful. I will defend it till I die. Very helpful. And in this particular case, regardless of what the main studies show, I agree with you. I would treat it with both from the get-go, steroids and MMF.
from the get-go.
I think that, I mean, there is clinical data to show that, you know, if you can't get the proteinuria under a gram, now you hadn't added a Flozin yet or anything like that, and you should probably, you know, obviously get to do that because we should be targeting proteinuria a little bit. But you could argue if they really haven't had a decent clinical response to ARB or a conservative care, which you already did, and the proteinuria went up, that might be a clinical indication to go ahead and start immunosuppression. And I think one thing that we don't know from the literature, which I believe, so in my opinion, in my humble opinion, is that this is a lifelong disease. And I think in the literature, we hopefully will start maybe start treating it like that instead of a 6-month study here or there, and seeing if we need a maintenance of some sort and treat it like lupus. Maybe we need an induction and then a low dose something forever to keep them from having inflammation. And that might be where the budesonide comes in. If it's, well tolerated, low dose, not having systemic steroid effects, that might be enough to. It hasn't been studied that way. I'm not saying we use it that way right now, but in my mind, it'd be nice to have something as induction, and then something to maintain them in remission over the long term, and as least side effects as possible. That hopefully will be where we're going in the next 10, 15 years with the literature.
Bill, what do you mean by induction?
Yeah, so maybe do like you would with lupus, or Cellcept, and slightly higher dose prednisone for the first 2 to 3 months, and then start to go to either low dose Cellcept like Roger's doing, maybe indefinitely, maybe not, or maybe you could switch them over to budesonide for maintenance. I'm not, again,
So would you
do
the traditional pulse like we used to, or what?
Well, I mean, there's not even data for pulse versus oral and
right, but that's
randomized
why
in lupus,
I'm saying, what do you mean by induction? Because
yeah,
induction in lupus is one thing, and this is not induction, is it?
Well, he went prednisone first, and then he said he was going to add on MMF. But I'm saying that, and again, I'm not saying this is out there in the literature. I'm just saying that I've seen a lot of progressive patients of IgA nephropathy over 20 years where I've hit them with steroids every once in a while when I see the proteinuria go up, and I do things for 6 months, and then I find 20 years later they're being referred for transplant, and maybe I should have had some low dose something the whole time, and maybe that won't work, but I do know that it seems to me that a lot of the progressors progress despite everything that we do, and maybe we need to rethink the way that we treat IgA nephropathy long term.
One of the things that came up was put her into trial, and I'm a big fan of that for IgA nephropathy. I was a little worried for her because my bias is so strong that she needs immunosuppression. That's a bias. It may be wrong, but that was my bias. I don't want to get her into trial. That's just you doing something hemodynamically or something, Budesonide, I don't know. I would want something a little more. I mean, I would be more interested in like a Vacopan or treating like a vasculitis or something, but. This is what we're going with. We'll have to see how she does. I don't know. It's going to be tough. I think a proteinuria will get better, and I think that may be our sign here, because for whatever reason we don't have hematuria to follow. Any other comments? All right, I'm going to wrap this up with a birthday wish happy birthday to Dr. Glassick last weekend. Happy birthday, Dick.
Thank you very much.
Yeah, it's great to have. Yeah, and we'll keep your eye out for emails. I'm not sure if we'll be back next week or not, but we'll let you know. And until then, everybody stay safe.
Roger?
Yes, Mario.
Can I say something on behalf?
Absolutely.
In reference to Dr. Glassick, he reminds me of a Spanish guitar. And the reason is because the older he is, the better he sounds.
Thanks,
Happy
Roger.
birthday, Dick.
Thanks.